All right, everybody. So welcome to the Clinical Consultation Network. As always, we have great presenters lined up for you today. So I am going to let Rita and Sarah both introduce themselves, tell us how you got into the field, and how one interesting fact about yourself or whatever you'd like to share with the group. We've talked about alternatives to those interesting facts in our pre-banter. But yeah, so just introduce yourself, what you do, how you got into the field, and interesting fact. And I guess we can start with Sarah.
Okay, so my name is Sarah. I'm the behavior analyst at Middle Tennessee Homes. I got into the field. I was a psychology major in undergrad and worked in an autism research lab, which sparked my interest, and kind of the rest is history from there. You know, went to grad school, moved out to Nashville, got a job as a student support teacher, sat for my BCBA exam. I've been a behavior specialist in Williamson County, and now a behavior analyst with the state. My interesting fact is I really like ketchup. I eat it on like everything, like a bean and cheese burrito, eggs, potato chips, bacon. Yeah.
That might be my new favorite interesting fact that anyone's ever said. Is that I really like ketchup.
Yeah, I didn't realize it was something interesting until I no longer lived with my family and realized that not everybody just like has the ketchup bottle sitting in the middle of the dinner table for like basically every meal.
Do you carry personal packets of ketchup around with you?
So not right now, like I haven't in a while because of quarantine, but yeah, I definitely like if I was packing a bean and cheese burrito for lunch, like I would make sure to have like individual ketchup packets because I don't like to eat my burritos without ketchup.
I love this. So if you had to pick the weirdest thing you put ketchup on, what would you say it is?
Oh my goodness. See, that's taking this a step further and I just am not prepared.
What is shocked to others that you put ketchup on?
I think the burrito is the weirdest thing. I was telling Rita, like I grew up in California. In California we have, I think it's in Georgia too, a chain called Del Taco, but they serve like burritos and then they also serve hamburgers and French fries and stuff. And so they have ketchup there for the French fries, but I always got ketchup for my burrito. And I was always confused why Taco Bell didn't have ketchup packets because they served burritos.
Well, like they have fries now, so I think you're saved, right?
Maybe, yeah. I mean, it's going to be a game changer. But yeah, if I went to like a fast food place and got a burrito, it was always Del Taco because they had ketchup for me. And I just thought it was something that Taco Bell was lacking until I talked to my parents about it one day, and they were like, "We've got to talk to you about this."
You have to talk about your ketchup problem.
We all had a ketchup problem though, so it was more so like just informing me what to prepare for in the real world.
Generalization of ketchup, apparently.
Yes.
All right, Rita.
Hi, everyone. My name is Rita. I am a speech language pathologist. I got into the field because I was really interested in the sciences in college and studying neuroscience, but then I realized kind of through the process of doing research that I wanted to do something clinical as well. Just skipping ahead, my fun fact is that I'm a musician. My main instrument is violin, classically trained, but now I do more like folk and bluegrass and whatnot. But I think because I was a musician, I have always valued expression, and I felt that speech language pathology was such a perfect transition into helping people express themselves and then helping them to be heard as well. So that's what got me into the field.
Well, that's awesome. So do you follow other musicians who play the violin?
Like on social media and whatnot, or?
Well, no, just like, do you have any favorites?
Oh, I guess it depends on what genre we're talking about. I think for bluegrass, I love Stuart Duncan. He played in groups like the Goat Rodeo, if you've heard of that, with like Yo-Yo Ma and Chris Thile and Edgar Meyer. What a group. But yeah, I guess
Yeah,
a few different ones, but
yeah.
I'm not too picky.
Well, that's a really cool connection. So your pre-meeting, guys, about your interesting facts, you did really well. So you passed the test there. So
Perfect. We're ready to go on to the next phase.
absolutely. So my understanding is that today we're talking about behavior as communication and how we can look at that from a person-centered angle. So I will let Sarah share her PowerPoint and you guys can kind of launch in. And I'm sure I will interrupt randomly. But if anybody has questions, feel free to unmute or you can pop them in the chat box and we will get to them as we go through.
Perfect. Okay, can you hear me? We're good to go?
Yep.
We can see the presentation?
Yep, everything's good.
Okay, so thank you for the intro, Michelle, because that actually helped with the transition. Yes, the title of our presentation today is Behavior is Communication. Are we ready to listen? Rita and I work together at Middle Tennessee Homes and have collaborated a lot just in different scenarios and situations. And we feel like we're always kind of having these conversations as providers around just how can we always challenge ourselves with this person-centered thinking and really understanding the person that we're working with. And so we just felt like we would present on that and dive into those conversations here. Michelle, please interrupt. We would like for this PowerPoint or this presentation to be more conversational. Rita and I are kind of going to talk and switch amongst each other. If there's questions or anything, we're happy to have as much participation as you want. Let me see. Hold on. It's not. Okay. Next slide. Okay, so we put this up here. They're having a behavior. This is typically when I get involved in a situation, and this phrase is one that I have definitely heard working in a variety of settings, and it can sound a lot different, but usually there is something going on right now that is challenging, and we need to address this. But it is my job to take this a step further and really understand, or multiple steps further, and really understand, well, what is it that we're talking about? What is the behavior even? How much is this impacting the person's life? And then, why is this happening? What can we do? And diving into all of that. So first and foremost, when we talk about just the word behavior by definition is the activity of living organisms. So anything that humans do basically is a behavior. Me presenting right now, that is a behavior. So realizing that behavior is so broad, and that when we engage in behavior, that is a part of being human. We all engage in problem behaviors. We all are working on skill development and replacement behaviors. And so using that knowledge to then take this to the lens of the person that we're working with and really center that focus around person-centered thinking about this behavior, right? Take this away, or not person-centered thinking about the person, taking this away from, okay, they're hitting, and really looking at what's going on, what's happening in the context that they're in, where are they successful, where are they not successful, or where do they need supports. And so we then, basically as the behavior analyst, I have this conversation. It is my job to educate people on this, so I have this conversation a lot where I go back to kind of this dead man theory, and I know that sounds a little bit morbid, but basically if a dead man can do it, then it's not behavior. And if a dead man can't do it, then it is behavior. So really what that means is, if we're saying we just want them to stop, I just don't want them to hit anymore, or they just need to stop saying no, we need to realize that we're not then talking about how we're going to work with them and advocate with them to get their needs met. So working on not just stopping and having them sit there like a dead person, but really being involved and engaged in their environment and learning to advocate for themselves or to get their needs met, so on and so forth.
Yeah, the dead man test is definitely something that is taught to BAs very early on in the process.
Yes. Yes, I remember when I heard it the first time, I was like, I don't understand. Then I realized we don't want, because it's such a good example, because a lot of times when you're working with people, especially as behavior analysts, we walk into very stressful situations because of the behaviors that are going on and just the history of those behaviors. And so a lot of times I'm working with people who might be frustrated with the situation, and kind of this helps us as a team step back and say, okay, well, what are we addressing here? And what are we wanting to teach them? Okay, so overall for our presentation today, basically the format is that we're going to start with the person's point of view and really focus on this person and, what is going on with them and their biology and their psychology and medication and all the therapies, all of it, really looking at this person and from a person-centered lens, diving into what they want, what they need, being a participant in the decisions in their life, right? And then taking this and considering the context that they live in, that all of us live in each day, right? Really looking and making sure that we're looking at this behavior, we're looking at this person, not just during this time where we're seeing this problem behavior, but during times where they are successful and seeing what's going right there. And then from here, creating meaningful supports with all of this information. Typically when I get involved at Middle Tennessee Homes, it might be somebody who's starting to engage in problem behavior, who's lived there for some time, but sometimes if there's a new admission, they might start engaging in problem behaviors that they've engaged in historically, but in a new setting, it is my job to come in and assess that. And I really need to take that into account, that they're in a new setting, realizing, is their house their home? Is the neighborhood that they live in their community? Or did they leave family behind in a place that they lived in before? Did they leave friends behind? And keeping all of that in my center focus when I am supporting them.
Yeah, it's really important to assess not only previous context for the behavior, but current environment, like you're talking about, and really looking at what you're identifying there is recent stressors that can influence that behavior as well. So behavior doesn't occur in a vacuum, and it's very important to look at all of the components that may be contributing.
Absolutely, absolutely. Okay, Rita, I think this is your one.
Yes. And I think when we talk about the different components that are part of the behavior and just kind of stepping away from what's the behavior to seeing the person, I think one thing that's been really helpful for me to think about is the sort of roles that this person has in their life. I think usually when we walk in as a provider or as a supporting staff, we tend to think, okay, this is my client I'm going to see today. But also recognizing, yes, they may be your client, but they're also, if you click the next few times, Sarah, I realized.
Oh, yeah, okay. Yeah. I got this. Just let me know when to click.
I forgot to tell you ahead of time. We have some interaction here. But they could be someone's friend, and so when you're working with them as a client, thinking, what would this relationship look like if they were friends with someone? And then going to the next one, you might have to click a few times, that, there's more than just what we might see as a client when how they interact and their viewpoints that they bring in the history of their lives and what has been historically meaningful for them, but then also the sorts of roles they will continue to have as their life progresses. Maybe, when they're younger, they were a niece and a nephew, they will continue to be, but then eventually they will become an aunt and an uncle, or uncle. Or maybe there might be someone that you're not a client with, but you may see someone in the community and they're an audience member and they're just trying to enjoy the show of the movie or whatever it might be. And so whenever we work with someone, just recognizing there's so much that we don't know. And there's so much about the relationships that they've had with other people that have really influenced where they are today. I think it's very easy to just think about disability in the lens of, oh, they have autism, or oh, they have Down syndrome. But there's really a lot more to it than that. And so when we look at this next slide, it's a model that I have found to be really helpful for me in terms of thinking about the whole person and moving away from this medical model where we only think about the biology. We think of the disability. We think of whatever illness they have, and we think, how can we solve or fix that illness? Especially in our population of adults with intellectual developmental disabilities, we very much, almost pretty much every time find there's so many factors that come into play in thinking about what truly is health. So not only just their biology, but their psychology, like their mentality about things, and what we have a lot of control over is their social context in which they live. So what we'll do, because this is a lot of information, we're going to break down this biopsychosocial to better understand each of the parts and then how each of those parts relate to each other.
Just wanted to comment, there's been a few things in the chat box I want to make sure I get to. Janet just agreed that, that the phrase "they're having a behavior" is problematic. But Marie added, with more person-centered language, maybe we could train others to say things like, "They're telling me something and I don't understand what the issue is," or "I don't understand." And I think that's a great way to reframe that statement.
I think that's great too. And taking our, our training just does not involve our discipline, but how we approach that, and from that person-centered point of view. I love that.
Mm-hmm. And I think what I love about that statement too, that complements really well with this model, is that when you realize the complexities involved in everybody, but all these factors, you can approach situations not from a sense of fear, but a sense of curiosity of, there's something I don't understand. Let's explore and see what all could be going on. And through that openness and curiosity, you might be able to think about situations in ways you probably haven't before, and then be able to really make a difference.
Yeah, that comprehensive assessment piece is really crucial, and that's one great component that you guys have at Middle Tennessee Homes, is having that interdisciplinary team on site where you can look at things from multiple angles. So definitely something that should be best practice.
Mm-hmm. Certainly. And I think one thing that you realize as you kind of dive deeper into any one of these aspects, the biology, the psychology, the social context, is that even within that one domain, there's a lot of interaction of systems, and there's a lot of complexity involved. And that's especially the case for biology. There's factors we think about, such as the person's disability that they have. How does that present differently in their body? And how does that impact their, propensity for having other physical illnesses, or, any sort of compromise in immune function, all of that. But then you realize the ways in which they interact with each other. So for instance, if you have a lower threshold in your stress response, due to your neurochemistry, so due to releasing, now you have stress all the time, you release cortisol over a long period of time, your reactivity is much higher to certain events because you are so stressed all the time. And then that can increase your likelihood of having a physical illness because of that stress. You look at how, like in your neurology, we talk a lot about neurodiversity here. And when we talk about neurodiversity, it's not just a statement that we say, it's really based on our brains being different. A more specific example, they've found, in general, when we look at the world and we process information, we have to integrate all of our senses together. So what we see and what we hear, for instance, has to be bound together in our brains to really make sense of what someone is saying. But they found that for people with autism, their ability to synthesize that information together is significantly more difficult for them. And actually their ability to do that is directly related to their language skills, their autism symptoms that they have. So if you have a harder time integrating those senses together, you might present with more severe symptoms of autism because of that. And so when we talk literally about seeing the world in different ways, it's true. And so you would imagine then how stressful it could be if you have a harder time processing that information, synthesizing it together. Situations that may not be stressful for us could be really stressful for them, and interacting with others or trying to be in a group and processing what everyone's saying. You can then see how that would be directly related to the sorts of stressors that they have, illnesses, all of it. Another important part of this biology model is just thinking about medication. You know, like how many people have we met in our lives, including ourselves, where as soon as we had medicine for whatever ailment we needed, it was like life-changing difference. Or on the flip side, if you are on a medication and it's not really working for you, you really see a difference in how you feel and your health. And so that's a major part of it as well. I think this ties pretty closely to what we see from a psychological perspective. I think this has been conversations that we've had that we've heard before in the clinical consultation network, but just like recognizing that many people with intellectual developmental disabilities tend to also have different psychiatric disorders such as depression, anxiety, post-traumatic stress, which we'll talk about in a moment. And it's challenging, this diagnosis in this population, not speaking from a psychiatrist or a psychologist, but just from observation, that if you have difficulties in verbally communicating or communicating effectively, it may be harder to describe some of what you're experiencing or what you're feeling, which may lead to some diagnoses being underdiagnosed. Or maybe, you know, you try to guess and you try to gauge as a team what's going on, but then somebody ends up being inappropriately diagnosed. Or maybe they have some symptoms, but because they present so differently than someone that's neurotypical, it might be harder to treat. Or because it's not recognized, it might be harder to treat as well. And I think, go ahead.
Sorry, I was just going to add, I mean, it really is a serious issue. And we talk about, you know, diagnostic overshadowing a lot, when a lot of what they're seeing that may be symptoms of that mental health disorder are just attributed to their ID or their DD diagnosis. And that really leads to, like you're saying here, them not getting the treatment that they need or not finding ways to adapt the treatments that are available. But that's definitely, you know, one of the big issues for individuals with IDD who have that co-occurring mental health disorder.
Mm-hmm. And you kind of see some of it kind of play together too. Like imagine, you know, for some of those that we serve who have difficulties with flexible thinking and that executive functioning of, you know, that gray area, not everything is black and white. And that's a key characteristic of having depression, you know, is that black and white thinking. And so it seems like for this population, some of it might be due to the biology that they have and their, you know, neurodiversity. But to be honest, a lot of it has to do with experiences that they've had in their life. And very unfortunately, there is a significantly increased prevalence of traumatic events that the IDD population goes through. And there's a lot of reasons for that. Their decreased mobility, like they can't escape or they can't get out of the situation. They might have compromised communication, so consent or being able to communicate about what has happened can be challenging. Or maybe they get into certain situations because of difficulty with reasoning. And even unfortunately, just being within a disability system and having that increased isolation from the community can increase the risk of having sort of trauma. There's some statistics that I found. So for instance, 35% of women worldwide have gender-based violence in their lifetime, but people with disabilities are up to 3 times more likely than other victims to be victims of those physical abuse, sexual abuse, or rape. And that, and in terms of being exposed to the disability system, your risk of abuse increases by 78%. Like, wow, that is awful.
Yeah.
And so, so in terms of the attitudes and beliefs that you would have about yourself, I think we really have to have a trauma-informed perspective.
Yeah, definitely always something you want to keep in mind, even if they haven't experienced what we might consider those larger traumatic events. They've had adverse experiences. The statistics are out there, to show that it's a very high prevalence of adverse experiences for the IDD community. And it's one of the reasons, in addition to some of the other things you've been talking about, like executive functioning deficits, that put them more at risk for crisis. Which is where you start, seeing those more extreme challenging behaviors, and then interaction with emergency services and crisis services. And it just kind of can spiral from there if it's left untreated.
Certainly. And I think that's why, in terms of supporting, this population, like having that trauma-informed perspective can be so crucial, even especially like the understanding, like not only is this trauma, but how does this relate to disability, and really coinciding those supports together seems to be what's most effective. Another factor that they talk about in the biopsychosocial model is the social context. And what I immediately thought about when seeing that model was remembering from the person-centered training class that we did of relationship maps, and just thinking about like, who are the people in their lives. And what I have found, and from my own work, that using this model with clients, is that oftentimes there's not really that many people in their lives that are not paid to support them. So they might list a lot of like staff people that have meant a lot to them, or they might share like aides that have come in, or therapists, or whoever it may be. But especially when it comes to friends that they have, it's more likely than not they're going to have a harder time with that, especially depending on the environment they've been in.
And one thing I really like to, make sure you point out when you're doing this kind of eco mapping, if you will, for an individual, is also recognizing relationships that are strained, because those can impact things as well. But yeah, I mean, when you really kind of break it down for a person and look at, is it a relationship where both persons are benefiting from something, or is it a paid service that's provided? A lot of people do not have a lot of natural supports, or even family, that they're involved with, and really trying to figure out ways how to build that, whether it's through friendships or reconnecting with family, or just establishing those kind of supportive people that are not there because they're paid to be there, is huge, and really impacting someone's quality of life.
That's a really good point, Michelle. And then there was something I was going to say, but it went out the window. Okay, I remember. Okay. So I think that's a really good point, because even though we might have good relationships with a client, and sometimes you say like, oh, they feel like family, which, depending on the context, maybe part of that's true. At the end of the day, though, we are paid to do it. So it isn't the same as like a true natural support that is there.
And then if they do have that close relationship with somebody, and that staff no longer is employed, then that's, huge loss of relationships. And that's kind of one of those adverse experience factors that your favorite person that you get to see multiple times a week all of a sudden is gone. You have no contact with them. You don't always get an explanation. So, I mean, that can be very traumatic, and it kind of aligns with, Janet's comment in the chat box about a lot of the times within the way the service system works with availability of services, people do get pulled away from their natural supports, or their family, or their community, in order to access services that are needed. So, I mean, that's definitely something as a system I think we're looking for ways to try to prevent some of that and get those services in their home environment and at an early enough time that it's not to where the family feels like they can't do it anymore.
Mhm. Certainly. And I think all of us have kind of experienced that to an extent during the pandemic of recognizing like when you don't have that access to community like you did before. Like I know I can speak to a lot of people, you know, myself included, like when you don't have that same sense of community, you might feel more stressed or you might, you know, have a harder time coping or feeling supported, you know, truly. And so recognizing that this is people's reality and also amplified every single day.
Yeah, absolutely.
You know?
I mean, if you don't have empathy for feeling isolated at this point, then you probably were doing the pandemic wrong.
Right. Certainly. And I think it does prompt reflection then on what community needs for someone, you know, and thinking and not just about, you know, what sort of behavior they're having, but within the context of their community, what do their relationships look like? Who is involved and not paid, you know, and who's involved and paid? Thinking about, you know, there's some people who maybe they're not in a position quite yet to be able to have a job for a wide variety of reasons. And even though a job and an occupation can be very fulfilling and provide purpose in life and all of those really nice feelings, when you aren't able to have a job or you're not in a position for that, what sort of supports are available? You know, what sort of skills could you still be working towards or have accommodations for to be able to have that sense of community? And then through that, it helps to kind of think about how to create this social network. Like who could they write to? Who could help to visit them? How do we help to cultivate that feeling of community in whatever way is most meaningful for them? Because so often I think because it can be really challenging to be able to figure out how to best support someone being able to go into the community. It can feel like a whole separate world, like we're going into the community and it feels like a completely different world when really it should be more connected. And then even if you go out into the community, it doesn't necessarily mean that's connection either. That's a whole other level from just going to somewhere to finding connection with someone.
Yeah, and I think the point you made about, you know, making sure it kind of goes back to that important to versus important for, making sure that you're making those goals in the vein of what the person actually wants, and not what you think that they should have to be a healthy and whole person, but really to tap into what they want. And obviously there's got to be some encouragement in that to get them, you know, to try and experience new things. But it's really important to focus on what goals the person has and taking those small actions towards those as much as possible.
Exactly. And we're just about to hop into that too, which is a perfect segue. But all of that to say, we are complicated. Every single person is not easy. And it's not. And so when you think about any sort of situation, it always is deeper than what we think. And I think when you realize all the ways in which these factors interplay with each other, it really is an exercise of compassion and the practice of it that's imperfect. But I think every day just helps to remind us of just everything involved with anybody, including ourselves, and just kind of helping to reflect on how are these factors influencing ourselves, even in these interactions. But all of that will lead to supports that we then develop.
Okay, so taking all that wealth of knowledge that Rita just discussed, you know, and talking about that with the team and educating ourselves on that as professionals, we must make sure that our supports that we're providing fit our clients' multitudes, so fit all aspects of what we just discussed. We need to push ourselves as professionals to know and support this person in as many ways as possible. I talked previously about, you know, just observing them in different contexts, educating ourselves on, you know, their disability or any sort of medical impacts that they're experiencing, and just making sure that that assessment piece is addressing all of those aspects to the best of our abilities as professionals. Obviously, as a behavior analyst, I'm not going to try and dive into this person's medical history and come up with solutions myself. But, you know, if I'm working with somebody who might be walking somewhere and then just sit on the floor, and, you know, I come and we're concerned because are they avoiding going somewhere? Or I also need to think about, well, what's going on in their body? What could be going on medically that could be impacting them? And making sure that I'm ruling out any, you know, aversive internal stimuli or, you know, just negative events that they're experiencing internally that I can't measure before I'm just saying, okay, we're going to handle this situation in an environmental approach.
Yeah, and I think you bring up a good point. You know, you have to stay within your scope of competence, but that doesn't mean you can't educate yourself on these different factors in the biopsychosocial model. So knowing side effects of medications that the person's on can be really huge, and in learning that, oh, maybe they're nauseous. Maybe we can talk to the psychiatrist or the PCP or whoever's prescribing those medications and say, is this a possible contributing factor to this issue? But I mean, it goes back to that need for that interdisciplinary connection in whatever way or format you can get it. But I mean, educating yourself as a clinician or a staff or in whatever your role may be, I mean, that can be really helpful information to have to really try to rule out and dig into, you know, what's contributing to the issue here.
Absolutely, absolutely. You know, and making sure that within our own discipline that we are taking in that entire wealth of knowledge into our reports, and that we're including it. You know, we're not maybe addressing certain details of it professionally, but we are still factoring that in and considering that and discussing that as a team. As a behavior analyst, I hate to admit it, but a behavior plan can't solve everything. Just my involvement in a team when we are seeing problem behaviors is not going to just all of a sudden, I don't have a magic wand where it's just going to be fixed. My job is to come in, assess, and brainstorm and provide a plan that will support this person. But for that example that I just discussed, where if somebody's choosing to sit on the ground instead of walk somewhere, and that's impacting their independence and the staff's ability to take care of them, realizing that there could also be medical reasons. And, you know, if I also realize, oh, they're refusing to eat their meals, or there's just several questions that you can ask yourself as a professional to make sure that you are considering this biopsychosocial approach in your interventions. And as Michelle mentioned earlier, at Middle Tennessee Homes, we do have a pretty strong interdisciplinary team of people who work together and collaborate together. And so we also understand that that's not how that looks in every single setting. But this is something that we just think is super important with providing person-centered supports, is that interdisciplinary assessment approach as much as possible. So when problem solving concerning behaviors, just bringing in as many of the team members who can be a part of that discussion, reaching out to people who might not be involved in a case, but need to be aware of something going on. So, you know, to kind of list who would be a part of this team, you know, it's the behavior analyst, the dietitian, anybody on the medical team, such as the primary care physician, a nurse if they're at the home, or a nurse who might consistently work with somebody, the psychiatrist if they're taking psychotropic medication, any medical specialist who has been involved in their case and might know them and know their history, psychologist or mental health professional if they're available, and then therapy, the occupational therapist, physical therapist, speech language pathologist. It could go further out than this as well. I'm sure that we could create a list a number of other roles that could be involved, but just making sure that as many roles as possible are involved to understand this person through that whole approach.
Yeah, just a few comments in the chat on that piece, the interdisciplinary piece. So Mickey commented, balancing obligations and outcomes against their clinical and social validity is our responsibility as clinicians, as behavior analysts as well. and setting boundaries is critical. Brad, one of your team members, added that the challenge for every discipline is bringing your expertise to the table, but learning to see the whole person. So I think that that's a great point. In order to be effective in whatever your area of expertise is, you have to kind of be able to look at and see the value in those other perspectives as well.
And Sarah, if you're willing to click through the next, I guess 3 or 4 times until I see a person in the middle. And I think that's the, thank you. I like animations, I guess. It's harder when you can't control it.
We clearly did not talk about the animations before this presentation.
Yeah, but I think that both of those points are so important, because ultimately, when you realize this is not a problem to solve, but like a real person that's whole, then it becomes even more important to both stay in your lane and then also be able to recognize how all of those factors influence your own discipline. Just briefly, I want to give a shout out to our nutritionist that's on our team, because she does a really nice job of thinking holistically with the supports that she provides from a nutritional standpoint. For instance, there is a woman who we serve who was overweight, and she provided a really good nutritional plan that met her medical needs of her, losing weight, but she also incorporated goals of figuring out for her, like, how can we make decisions about healthy eating and healthy choices? So let's go to a restaurant every week, and we'll go to the same restaurant, and that way you can practice like looking at the menu, seeing some healthy choices, and making that decision for yourself too. So not only are you empowering her, this client, with the information, right, so that way she feels capable, you're also providing a really good social opportunity of going to the same restaurant every day, not every day, every week, but being able to meet the same sort of people, getting to know the manager, getting to know the regulars that are there. And so not only then are you working on the nutritional goals, but by proxy of doing the nutritional goals, you have these opportunities for social engagement and helping this client feel empowered and capable of not only making these choices, but building relationships in the community. And I think that's a great role model for all of us and how we could approach these assessments and ultimately the supports.
So going on from there, basically what Rita was just saying is, how can we make, we've talked about as professionals what we can do with this approach, but also how can we make the client an active participant in these discussions. And we kind of already talked about this, and Michelle, I know that you kind of addressed some of it as well. But what are the goals that they want to work towards? They might not line up with the goals that we want them to work towards, but making sure that we are sitting down and listening with them and hearing them and factoring those in as well. What do they want their day to look like? Once again, that might be different from what we might be able to do, but listening to them and what matters to them in their day, and making sure that we are working with them and creating that schedule. How can we help them have control over their life? That is something within our specific organization. We work with a lot of people who are medically fragile. And so a lot of times they need a lot of support with just daily living skills, like self-care activities. They have people help them when they shower, when they use the restroom, where there's a lot of things that might be out of their control because of medical recommendations or things that are in place to keep them safe, to keep them healthy. But keeping that in mind, and then realizing how can we help them have control over their day so that they want to be a part of that and be an advocate in their day. And how are we educating the clients on what they need? Rita, I thought that when we were kind of talking about this, you brought up a great example from Harold Jordan Center as far as psychotropic medication that people there receive. Do you want to kind of touch on that?
Sure. So I also work at the Harold Jordan Center. And what I love about what nursing does with their clients is that they have a whole program where they teach the residents about their medication, how to say their medication, how much they get, and how often, how it helps them. But the ultimate goal that if they're able to, and when they go into the community, be able to be more independent in their ability to administer medication, but then also just understanding like why the medicine's helpful.
Mhm.
And I think that's great.
Yeah, I was just going to say, educating them on what they're taking, why they're taking it, educating them on the side effects of their medication is huge so that they can report those potentially. But there's tons of enabling technology, and I know we have teams across the state who just focus on this. There's a lot of enabling technology out there that will, prepackage meds and remind people to take meds. So there's definitely a lot of good things in place where you can get people to be doing those things independently.
Yeah, absolutely. And with all of this in mind, also realizing that if there are limits in communication of a certain client that we're working with, that should not limit how active of a participant they are in these decisions. And so working with them, maybe they're not going to tell us through words and sentences, but watching them, have them be in the room when these discussions are happening, seeing how they're reacting, their facial expressions, and their engagement in what we're discussing, and just making sure that we are doing everything we can to push ourselves to include people who might not be as intentionally active to include themselves. So then going from there, once we kind of, we're assessing, we're talking to the client about what matters to them, and then we're working with them on identifying person-centered goals. Their wants and needs matter. And as we've said before, the goals we have may be different from the goals that they have, and that's okay. And we need to make sure that both of those goals are discussed at the table. Specifically as a behavior analyst in my field, one of the behaviors, that we'll target is when somebody is refusing to do something or saying no. We will call that non-compliance. What we always want to ask ourselves is non-compliance to what? We'll say, well, they're not listening, they're not doing this. Well, is it to our vision or their vision? And realizing that we need to address that, not to say like, oh, if it's what they want to do, then they just get to do it and we're not going to intervene, but teaching them more of an effective way to advocate for themselves, realizing, okay, you're not ready to do this right now, teaching them, hey, give me 1 minute, or not right now. I think about it for me, if somebody came in and said, at 3 p.m. it's time for you to eat dinner, I would probably say no. And that person could very well say, okay, well then she just doesn't want to eat dinner today, and just leave, and say, well, she's just refused her dinner. But for me, I like to eat closer to 6, but it's working with people to help them advocate in ways that we already advocate for ourselves.
And there's definitely a double standard, I think, when it comes to thinking that people are supposed to be compliant. I am non-compliant all the time. I don't always follow my doctor's recommendations. And I think it's really important that we teach people that they have the right to say no, and they have the right to make those choices, and to try to encourage them to make those healthier choices, or whatever it may be, but to understand that they do have that right as a human, as any of us do, to be able to say no, or later, or I'd rather do it this way. So that's just really important piece.
Absolutely. And then finally, as far as person-centered goals, what makes their life fulfilling and what gives it purpose? I don't know if it was on the Clinical Consultation Network or another presentation, but it was during a presentation that I was listening to, and the presenter talked about making a list for your day in 2 different ways. One list being your to-do list, and one list being a list of things that make you happy, and then reflecting on that and thinking, do these line up? And I kind of reflected on that for myself and realized that the things in my day that made me happy, I wasn't really intentionally factoring those into, my day. If I have a list of chores that I need to complete that day, factoring in, taking my dogs for a walk or going outside and playing with them for 5 minutes. And so, making sure that we're not only doing that for ourselves, but we're doing that for the people we work with, not just making their day a checklist of things that need to get done to keep them safe and keep them healthy, but of things that they want to engage in and be a part of, and things that make them happy.
Yeah, I mean, that's definitely something that the START model focuses on. They call it PERMA. But, making sure, like you're saying, that they have those opportunities for positive emotions, that they have relationships, that they feel engaged, that their day is meaningful to them, and finding ways to create that, figure out what their strengths are, and really utilize those to accomplish maybe some of those more like we kind of need to do this tasks versus some of those more preferred tasks, and really engaging them in that conversation and planning.
Yep. So once we've identified these goals, going the next step, right, and working on skill development. I feel like I always say, and all of my, probably I'm sure most of my plans, if not all, have phrases of tell them what to do, not what not to do. Going back to kind of that dead man talk that we discussed at the beginning of this presentation of working with them and advocating with them on skills that we're going to teach them, so there's just a list of, what can we teach, and the list goes on, but we've listed, prerequisite skills, social skills, communication, self-regulation, self-management, problem solving, medication administration and education, self-care activities, any activities that they need to be involved with daily living. How can we make them as independent as possible in each of those activities? Mobility, Rita talked about this, with health conscious eating and healthy choices. The list goes on.
Yeah, and I think, it's really, you have to get creative sometimes to incorporate everything. And a good example is something that Mickey put in the chat box. They had a child with weight issues that was refusing to eat, and so they kind of set up a behavioral momentum strategy where they were having that child help to cook and prepare dinner and taste things along the way, and so that's just a really creative strategy for trying to accomplish whatever the goal may be, whether it's their goal, your goal, whoever's goal. But just really trying to figure out a way to get that done without just saying we're doing this whether you want or not.
Yeah, absolutely. And then also too, it's like just to think about the skills that you're teaching them within that behavioral momentum, that sequence of working on this behavior specifically, but now you're leaving this hopefully with that behavior decrease, or they're eating more, and they've also learned these skills in addition to that.
And I think what it's kind of picking back off of this, is just kind of the point of this slide, and kind of in response to Marie's comment about, how we think about the supports that we give. I think, when we tend to think about supports, we tend to think about, okay, these are all the skills that we are going to teach this client about what to do, which yes, skill development, empowerment, all that stuff. Great. But also recognizing that in order for true connection to happen and for true change to happen, we have a lot to learn, and that there's skills that we need to develop so that way we can best support our client. And we can't always expect all of the change to come from the client. So for instance, I think all the time for people that use communication devices that, their array of communicating is going to naturally be different because they're using a device instead of verbal communication. And so we have to learn how to be communication partners for them, for communication to really be effective. But when we are able to develop our own skills and being able to meet them where they are, right? And they're also developing the skills to meet us in the middle, right? And then that is how we are able to get empowerment. And with that empowerment allows us to support their autonomy. So thinking about, again, can they teach us? How do we be open to what they need? How do we involve them so they feel like they have control and they have agency, right? And such as like cooking their own meal, like it gives them control over what they want to do. And being willing to have conversations that can be uncomfortable sometimes, from education to their vision, whatever it might be. I think those conversations can really open the door to really understand where they're coming from and what they need, right? Rather than just taking things away. Or even thinking sometimes, well, yes, we can give them skills, but there's certainly sometimes supports and accommodations we could give them. So that way it's whatever we're doing is more accessible for them. Maybe it means taking more breaks. Maybe it means, helping with their communication, or even just having a ramp to, you know, go up the stairs. That's a really good accommodation for someone that's in a wheelchair. And just making sure with these questions that whatever inclusion that we have is really meaningful.
So kind of wrapping this up with all of this in mind, as the pandemic ends, hopefully sooner than later, you know, and we start working with clients and going back out into the world and shopping for groceries and, you know, eating in their community, realizing how has the pandemic affected them. You know, it's affected all of us. So, you know, what are the effects of the pandemic on our bodies, on our mental health? You know, thinking about the fact that a lot of the people that we work with might have not seen family for a year so that we could keep them safe, and what the impacts are of that. What are the effects of the pandemic on future interactions with others? What are the effects of the pandemic on our skill sets? Realizing that, you know, we might not be able to pick up where we left off when the world shut down, and how are we going to build on those skills again? And how our supports look different going forward in regards to assessments, goals, skill development, and supporting autonomy. Rita found this quote, and I'm going to read it, but it says, "The way of the miracle worker is to see all human behavior as one of two things, either love or a call for love." So when we're intervening on behaviors or problem behaviors, we need to stop ourselves and think, you know, which one is it? And that's our presentation, Michelle.
Well, I really appreciate your presentation, and I think you guys touched on some really good points. But we are out of time, so we don't really have a lot of time for questions or discussions, but I think we've gotten to most of them in the chat box already. We do have some good praise coming in for your presentations, so be sure to see those. But again, thank you, Sarah and Rita, both for this presentation. We are doing the Clinical Consultation Network and continuing to do it every Tuesday at 12:30 Central Time. So check out our recordings on the website if you need to, and otherwise we will see everybody next week.
Thank you.
Yes, thanks,